I'm joined with Patti Robitaille. Patricia, thank you for joining me today.
Oh, it's nice to be here. Thank you so much.
All right. Well, I want to start with your background and why HCQIA, why the Healthcare Quality Improvement Act why you're so passionate about this. Could you tell me about your background, maybe what you saw or what turned you on to this issue, and we can go from there.
Sure. So I'm an emergency medicine physician, and I've been practicing for 35 years. During that time, I've been on the credentialing committee for 20 years, the last 2.5 of which I was chairman. So I've seen a lot of peer review in that arena. And I had somebody who was close to me ask me questions about the misapplication of peer review. And so I can't really talk about that particular case, but it got me going to looking at the law, looking at doing research and so forth. And so it's a law that really needs to be revised and reviewed and reformed. And that's for the betterment, not just of physicians, but also of the patient. And it's important to know that this law is not just about physicians. I might use that word all the time because I'm a physician, but it also applies to PAs, nurse practitioners, RNs, clinical psychologists, and other licensed healthcare professionals.
So it's a really wide net there. And let's go back to the beginning of the law, 1986. And this law was really put forward for some good intentions, because at the time there were physicians were independent. Imagine that. And they were independent and they could go from state to state. So if you had a bad physician, they could just jump ship, pack up their goods, go to another state and continue to be a bad physician. So this idea of trying to protect patients and trying to protect hospitals from bad physicians is where HCQIA actually started out, this Healthcare Quality Improvement Act. But what changed from 1986 to now when it comes to this act? How is this act being leveraged today compared to when it was started in 86?
So it's important to know why they wrote the law. As you mentioned, it was to keep people from moving from state to state. And so they were looking for incompetent providers, incompetent doctors. They wanted people to be able to report that. In doing so, they also created the National Practitioner Data Bank, which is a repository for the reports. So when you do credentialing, when somebody comes to your hospital, you check at the time that they're credentialed initially and then every 2 years. And that's true of other providers as well.
And this database, if one gets on this database, from my understanding, you don't get off this database. This is kind of a lifetime database of your practice as a physician. If you have a check mark against you, this is something that's held against you for the rest of your practice. Is that correct?
Yes.
Okay.
And there's actually 2 ways to get on the database, and one is medical malpractice. Whether you went through this peer review process and had a report, or whether you had a medical malpractice action against you, and it was paid out, whether you settled or whether you went to court and it was found against you and money was paid out. So that's the one way. The other way is that over time, this has changed where they've had the term disruptive physician. So if you advocate too strongly for your patient, you ask for adherence to policies and procedures or to your society guidelines, etc. If you make too much noise or just want to improve the process, you can be labeled as disruptive, and that will put you on the data bank. You ask the general public which is worse, they'll always say medical malpractice, but it's the disruptive physician label that will keep you from practicing medicine more so than the medical malpractice.
And so in 86, there was this idea where hospitals were community-based, they were somewhat independent, but they moved to corporations. Is that correct? Basically regional corporations, and you have these these corporate megaliths that are hospitals. In fact, there's about, I think I heard the quote from you, actually, there's 10 healthcare systems that own about 1,400 almost of these hospitals. I know Kaiser Permanente, the revenue stream is about $110 billion last year. So we're talking big, big business. Explain how the business model of hospitals changed from 86 when the inception of HCQIA, this act, to now.
So back then, 2/3 of hospitals were community hospitals. They were in a specific location, servicing a smaller population. Then in the 80s and 90s, what happened was hospitals affiliated. And of course, from a corporate point of view, it makes sense. it's less to buy linens, it's less to buy health insurance and, benefits for employees and so forth. And so 2 or 3 hospitals would affiliate and these 2 would affiliate. Well, pretty soon those systems became affiliated. And so now you have systems which have hundreds of hospitals and they buy up practices. So now they have, surgery centers and they have primary care and they're huge. Yeah.
So you're talking about, it's kind of like Pac-Man. It's just they're eating and they're becoming this hospital corporation with, so the bottom line really, they're accountable to the chief financial officers and shareholders as opposed to the patients. Would you say that would be accurate in switching as far as their business model?
Yes. I mean, in my mind, as a physician, the patient is always first. That's always been my guiding principle. When I walk in the emergency department, it's always the patient. So, but what you have is conflicting interests because it used to be you would have the medical staff and then you'd have the hospital. And the medical staff had their own bylaws and they were self-governing. And the hospital had a vision. So we're going to be an orthopedic hospital or for unwed mothers back in the day, whatever your mission was, and you adhered to guidelines and so forth, you were financially responsible. But as hospitals became corporations, then they also started employing the physicians directly. So instead of being an independent doctor, you were now under the umbrella of the corporation. So now the 2 spheres are almost overlap because 70% of physicians are employed.
And the financials are not necessarily a bad story. This isn't a bad thing if hospitals want to make money or if physicians want to make money or healthcare organizations have shareholders. This is just how it works in America. The problem becomes there's this tempting dangling fruit, which is the Healthcare Quality Improvement Act. And what did that do to this board? Because it created a board to investigate disruptive positions, like you said, or medical malpractice, really obviously for the safety of the patient. But you add this massive corporate hospital corporation, and now there's some temptations because this HCQIA has set up really like a star chamber, if you will, and the people that are participating in this have immunity and they basically have no discovery. So if you're a physician that gets brought up on what was called a peer review, but there's something now that has entered the picture which is called a sham peer review. So could you explain the mechanism of the sham peer review and also the immunity that's enjoyed by this council that's basically interviewing these doctors?
Sure. So when the law was written, it was written with a preamble stating that we need to give immunity to the person who gives the report. You've witnessed something, some medical malpractice or alleged medical malpractice, and so you need immunity as an individual. If you're serving on the hearing committee, you need immunity. And so that's what it says in the law. And when they granted immunity, they did give it to those people. But if you really look at the definitions in the back of the law, they actually granted it to the healthcare system. And of course, you were little hospitals back then, but now you've technically granted it to huge corporations. Wow. In addition to that, the states added confidentiality, which means we can't look at the documents, we can't hear what the discussion was, we don't know what went on in this process. And then privilege was granted by the states as well. And privilege is, I can't subpoena these documents, I can't compel you to testify. So in the end, it's all wrapped up. Once you go through this process, nothing comes out. So if you were the victim of misapplied peer review or sham peer review, you can't say, hey, wait a second, I'm going to file suit. Because if you do that, the judge says they have immunity, confidentiality, and privilege, and so I can't even hear the case. So wow. The piece of the law says, if it's malicious or if they knew it was false, that you could prevail and immunity was no longer. But how can you prove immunity? I mean, how can you prove that it was a sham if they've got immunity? Because they won't hear the case.
So a court cannot intervene essentially, and we basically have multi-billion-dollar hospital systems going around with private closed-door meetings that they can really do anything they want to physicians. Obviously, it sounds like a really bad idea.
Yes, and they so the real law was for malpractice. But then what's happened over the years is that they've now developed this disruptive physician label. And so if you speak too loudly, if you ask for things, if you're asking for higher quality care, they'll label you as disruptive. And then they'll put you through this peer review process. And in my mind, they're taking HR and they're putting in peer review, which it took me a little while to figure that out. But if you put it in peer review, again, it's a closed system. And
Yeah.
so they are now taking human resources, putting it in peer review, and they're avoiding employment law.
Wow. And so, has this ever been challenged since 1986?
So, of course, people have campaigned, they've, asked for change and so forth. It's not happened, nothing of consequence.
Has
I
the
mean,
media
it's
has the
hard, you
media
can't.
reported on this at all? I mean, it seems like this is a really bad idea in our culture of open sourcing everything, having all the information out there. We have activists in almost every part of medical community and public health community, but it seems like this has slipped under the radar. Why?
It's because it's a divide and conquer method. You have this little flame in the darkness of this inappropriate peer review or sham peer review, and it's just snuffed out immediately. And so I've talked to people about what's the incidence of sham peer review, and even experts in the field can't give me an exact number. But these little flames everywhere, I think collectively are a bonfire.
So I mean, it's essentially a black hole because when a doctor gets sham peer reviewed or their career is essentially destroyed, I would imagine, you don't see them going out. I mean, what happens to these doctors that are getting sham peer reviewed and getting brought up, putting on this database and essentially cannot be hired again? What happens to them?
Well, some of them just, you know, evaporate. They go off and do something else. It's a huge stressor because if you take all the stressors in life, losing your license, losing your job, having worked all these years for this career, stress in the family. I've seen people divorced, suicide even. I mean, there's cases of suicide with that. So, and some of them negotiate their way out. So the hospital says, okay, we'll let you go. We'll say that you left in good standing. You have to sign a non-disclosure. So those
Hmm.
people can't speak at all.
Oh, wow. Okay,
So
so and
there's a lot of things that happen to these people. None of them are good.
I've read some of the reviews. It's tragic to say the
Yeah.
least. And some of the reporting on it from way back in the 90s when this was going on, when there was actually reporting on this. So when it comes to okay, so let's say if you're a physician, you've spent a decade building your career, doing residency. I couldn't think of a better, I guess, uh, type type of job to get blackmailed into by this sham peer review. I mean, if one was, a job that they just got out of high school and someone brought them up on a sham peer review, they'd say, I don't need the job. I'm gonna take off. I don't need to handle this
Right.
stress. But you have that much invested into it. They hold a lot of power, this chamber of doctors with no names and no faces that courts can't compel to release any documents. They're immune from any legal action. It's basically behind closed doors. These physicians, I would imagine they're powerless at that point if a case is open. Do they even know? Can a case be opened upon them without their knowledge?
Yes. So that's one thing about this law is there's no due process. In my mind, if something's going to start, you need to announce that it starts. So you
Right.
can be under investigation by the hospital and not know it. So let's say you're leaving for some other reason. They think you're disruptive, you're leaving for another reason. And then you resign from the hospital, they can say, well, you were under investigation. When you resign under investigation, it's reportable to the data bank.
Whoa.
So they will
Wow.
report you. And once you've resigned, you're no longer a member of the medical staff. So you have no rights at all. So it's
What
double
are
whammy.
what are some of the things I'm continually thinking about a physician in this predicament? They find out that a case has been opened upon them. What are some of the things that these administrators call them that are running this peer review or a sham peer review? What kind of power do they have? What can they compel a physician to do in order to jump through their hoops?
Well, they're supposed to do this in good faith, and they're supposed to have good faith effort to investigate. But I've heard of cases where they say, you're suspended, you're done, we're not investigating. So they don't do anything. They don't follow the law at all.
Because there's
But
no recourse.
there's no recourse.
Yeah.
Yeah.
Yeah. Good. So good faith sounds great, but without any teeth or legal action or recourse, that it's kind of a wink and a nod.
The
And
other thing that can happen is that you can have uh, allegations made that are so vague that they're meaningless. So they could say, well, we think you may have had a HIPAA violation. Well, you could say that about anybody who touches an electronic medical record. In my mind, it has to be time, date, and patient specific. You did this on this date to this patient. So it has to be concrete. It needs to be harm, or it needs to be, foreseeable harm. You came in drunk to do surgery and we prevented you from doing surgery. It needs to be that. The other hoop that they can make you jump through is they can ask you for substance abuse testing or psychiatric evaluation. But
wow.
what they'll often do is they'll say, you need a psych exam, but you have the choice of this one or this one. So they tell you who you have to go to.
Oh my
In
gosh.
medicine, that's not how it works. If you have cancer, I don't say you have to go to this facility or you have to go to this doctor or you have to do chemo or surgery or radiation. No, that's your
Wow.
decision.
Wow.
So they really use the mental health as a weapon, and they can send you to physician health programs, and then you're stuck in a vortex for 5 years with that.
Can they wrap in your family? So I would imagine if they're saying you need a psychiatric evaluation, you may need to be hospitalized. We need to talk to your husband or your wife or your. Can they wrap them into this as well?
Yes, they can. And of course, if you were just an independent person, would you do that? But you've got to realize what's on the line here. If you wind up saying, and people do this, they make the error of saying, oh, I'll do a psych exam, I have nothing to hide. But then they
Right.
get sucked into this vortex that they can't get out of. And so yes, they can ask that. And the reason the person would say yes is because if they don't, they'll get reported to the hospital, and the hospital will report them to the state medical board and give them a National Practitioner Data Bank. So it all hinges on their career.
And minus the immunity from liability, minus the secretiveness of this. Keep calling it a star chamber, but of these proceedings, these sham peer reviews. What we're talking about here obviously sounds fantastical, but on the flip side of it, if a general public is listening and they say, well, that actually sounds like good, because if you do have a physician that is disruptive, actually disruptive or causing patients harm, we need this oversight. So what would you say to that? Because there's this slippery slope. Obviously, we just laid this out because hospitals have become corporations now. And when it comes to patient advocacy, if patient advocacy goes against bottom lines, then you have an issue. And I can think of about 5 to 10 different headings right now that patient advocacy would butt against corporate policy. One of them being the pandemic we just lived through with the COVID jabs. I heard a lot of stories from physicians saying, look, everyone on their floor just gave a wink and a nod and said, don't report any of the issues with the vaccines, any of the adverse reactions, because we're in a pandemic and we need to get as many people as we can vaccinated. That's just one I can think of. So if a physician said, you know what, I have 3 patients that came in this past week having harms directly after they were vaccinated, that person could be sham peer reviewed, correct?
Yes, they could be. And we do need to peer review those people who are truly dangerous to the general
Right.
public. I mean, I'm not saying that that's not the case, but the data is for every one medical malpractice peer review, there's 4 reports of disruptive physicians. That's
Wow.
backwards. That's not the intent of the law. The intent of the law was medical malpractice. So they're going after people who don't agree with the narrative or, advocate for their patients, the VAERS report that you're talking about, that kind of thing. So for the public, you still need good peer review. You need to let the physicians advocate, the providers advocate for you. There shouldn't be consequences. You shouldn't have employed physicians on your hearing committee who have a conflict of interest. They're being paid by the corporation that's asking them to be on the committee.
That's
So,
incredible.
yeah. So
And
there's,
yeah, go ahead.
and when you talk about the innovators, this is really a big deal to me. The innovators are the people who think outside the box. They're at the right end of the bell-shaped curve for competence, right?
Mhm.
So back in the day, whoever heard of heart catheterizations and stents, heart valves? Whoever thought of sucking all the blood out of somebody, cleaning it up, and putting it back in, called dialysis? We think of it as routine today, but it wasn't. It wasn't not that long ago. So these people have to be able to think and advocate and do their science, that's for sure.
And we're at a very interesting point right now in America with Secretary Kennedy at the head of HHS. The idea of medicine, public health, it's all changing, and it's changing with evidence. So, again, SSRI medication, we can go to early treatment like exercise or vitamin D during COVID. All these things were shut down, but the SSRIs, they're finding out that the evidence of harm is a lot greater than we were told. All of this is still is standard care. Even the routine childhood vaccinations, a lot of parents disagree with this because of the science showing that there are issues with some of these, or perhaps all of them we don't know. The science is still up in the air. I know Tylenol has been a big question right now in HHS. So if a parent comes in and says, look, doc, I don't know if I want to do this, whatever that medication is, and the doctor goes, you know what? This is between you and I. You're my patient, and I want you to be informed with your decision. And the hospital hears about that and says, this person came in, why didn't you put them on an SSRI? That's a possible sham peer review right there, right? Just for being a patient advocate as a doctor, as they should be.
Right. The thing that people don't understand is the term standard of care. The standard of care, if you take the bell-shaped curve of competence, it's what would the average person do with your level of training and your resources. It's the middle of the bell-shaped curve. Excellence of care is to the right-hand side. So you're looking for excellence of care, not standard of care, if you're the patient. And to me, I'm totally a minimalist at heart. You can't find more than ibuprofen and a Band-Aid at my house, and other people have cabinets full of stuff. So it's really talking to your patient, taking into account, their past medical history, what their comorbidities are, what their life philosophy is. What you might decide as a cancer patient when you're 30 is going to be different than when you're 80.
Right.
And that's not up to you as the doctor. That's up to the patient. You have to outline, these are your options, and where would you like to, and all the risks and benefits that go with it. This isn't the old days where informed consent was a piece of paper that you sign for surgery. That's what it used to be. Now, informed consent is really more of a global concept.
Absolutely. And I think of this because I've always been taught, and I think it's hopefully general knowledge now, that you don't walk into a hospital by yourself. You have an advocate, you have a family member, you have someone that's going to speak for you if you can't, or just be there to witness what's going on. Because there's been so many horror stories at hospitals. And I think about HCQIA and what it's done to chill physicians' behaviors. And I think about walking into a hospital and all the physicians are kind of looking around, kind of a wink and a nod, and thinking, remember Dr. Joe, who tried to do informed consent and have patient advocacy? He was put on the database, and he's out of a job, never to work again. So we all don't want to do that. So anybody that comes in, we need to do standard of care for them, whether they want it or not. And that's where I see these two heads butting, is you have a mother or a father or a family that comes in, or a child, and says, I don't consent to this. Those doctors have an incentive now. They're almost being ridden by this HCQIA Act at this point, because if they don't do it, they may lose their job. So that For me, that's one of the things that I never understood. Why would physicians try so hard to get parents, or even to call CPS on parents to get their children taken away from them if they don't consent to a vaccination or a mental health checkup or something like that? Could this be one of the reasons behind those things, that ideology?
Well, I think that you're right that when you're sham peer reviewed, you're an example not just to yourself, you're an example to all the people on the hearing committee if there was one. You're all the people in your department, all the people on the medical executive committee, they know what's going on. But again, you can't force somebody to do something they don't want to do.
Right.
You know, I've had people, huge blood clot in their lung, huge clot burden, needed to be admitted. And I don't twist arms hard very often, but he
Hmm.
needed to be admitted and he absolutely insisted that he wanted
Yeah.
to go home. Well, I can't make him stay, even though I talked to his family. And you know what? He did come back the next day. But yeah, you shouldn't be able to make somebody do anything. I've had people who don't want surgery, people who don't want chemo, people who don't want, any intervention. And I say, okay, well, this is the consequence.
Hmm.
And, this would not be advised, but it's completely up to you. And you just have to document it, document, whatever your
Yeah.
conversation was with the patient. And make sure, like, your advocate is there. I always say when I walk into a room, if there's 3 or 4 people, you all are supposed to remember a different part of what I say, because studies show you remember about 25% of what the doctor says. So all of you have to remember a different 25%.
Now, you mentioned something about bad physicians being purposely protected. So hospitals are for profit, and I don't want to paint this dark picture or go down this road, but has there been cases, because there's the sham peer review, like you said, and it's there and it's ready to be used and it can be weaponized, but have there been cases where hospitals, because doctors are making a lot of money doing perhaps, therapies on people that they don't need, where the sham peer review looks the other way, or this HCQIA Act, which is meant for these doctors, basically just shuts down?
Yes, and so what you're trying to get is right in the middle, those people who need to be peer reviewed. And where I came to this process was the inappropriate application of peer review and
Mm.
taking out good doctors. But then there's people who are poor physicians and they remain, and it's because they make money for the hospital. So there's the Dr. Dunch case, which is very famous, a neurosurgeon who was in Dallas. And in the course of 2 years, I think he had 38 patients. He maimed 31 of the 38 and two
Oh,
died. I mean, you can't ask for a worse neurosurgeon. And it took his colleagues at the hospital calling out, finally going to the state medical board and saying, you need to do something about this man. And so and then all these patients were coming forth and the same name kept coming up, Dr. Dunch, Dr. Dunch, Dr. Dunch. And so he was finally tried for medical malpractice. Not that the hospital did their job, but he was tried and he's in jail, actually. There's
wow.
a show on it called Dr. Death.
Mm. So the very purpose of the act is they're asleep at the wheel, sometimes with these. So you are involved in this. I know that you've spoken to me, before this, before this interview, said you have been able to give Kennedy a reform and a reformed version of HCQIA, because obviously we don't want this thing to go away and go back to the dark ages where doctors are saying and doing anything they want, and they could be medical malpractice and they can move from state to state conning people. We don't want that. But we don't want this oversight. This law is broken. It's because the system that we're in right now is a for-profit system. Billions of dollars are being made, and hospitals have an incentive to keep physicians in line and keep them doing the standard of care that they want, perhaps not the patient wants. So what does the reform look like? I know you've been working on this for quite some time.
So in the reform, and I know that most people don't do this, but you can always complain about something
Hmm.
and that doesn't get you very far. Then you can go to somebody and say, this is a problem. I need you to do something about this. But what I did was I decided to rewrite HCQIA. And I did this by contacting physicians who are who were peer reviewed in that manner. I talked to medical malpractice people, somebody from the National Practitioner Data Bank, healthcare attorneys, Mr. Tom Devine. He's a whistleblower attorney in Washington, D.C., and he wrote the whistleblower piece of the legislation.
Yeah.
So I took all of their ideas together and crafted a proposal, draft legislation. So the first thing is to assign immunity where it needs to be assigned. And that is to the person making the report and to the people who are involved in the process as far as the hearing panel and so forth goes. If you are the healthcare entity and you're doing things according to HCQIA as you're supposed to be doing, you don't need immunity. And if you're not doing it right, you don't deserve immunity. So that's the first part. It's really important not to use HCQIA for human resources. That needs to be gone. So if it's a human resources issue, it needs to be handled by human resources. If they're involved in the process, it should be null and void.
Right, right.
Separating medical malpractice from healthcare, so the mental evaluation, substance abuse, or physical illness. You could be physically ill and not be able to practice. Those should be handled separately. And the last thing is really there should be accountability, because right now there's no accountability. There's one place in the law where it says if you don't report when you're supposed to, we're going to fine you $10,000. Well, since this has been in place for 40 years, there's never been a hospital who paid anything. So it's like, we'll take a late report rather than no report. Yeah. So they've never been fined. There's no consequences for administrators or hospitals who inappropriately did peer review, because again, you can't hear the case. Or if you didn't do it and there's been malpractice, like the Dr. Dunch case. So we've inserted a National Practitioner Data Bank administrative subsection. So your hospital name would go there. You'd be getting a data bank report if you're an administrator who did false peer review or grossly missed peer review. And in the same way, if you're an administrator going to a new hospital, they need to check your credentials through the National Practitioner Data Bank.
Yeah, and all of this makes perfect sense. And the public has been essentially completely in the dark on this. I mean, there's really been almost no reporting. This isn't something that was in the Make America Healthy Again kind of their ethos. This is completely off the record on that. But when it comes to this proposal, no one's done, in my opinion, more work on it than you have. And you're really a luminary in this space trying to change this. Do you see entities that are pushing back on this? I mean, I know, when I look through the lenses of Big Pharma, they have lobbyists up in Washington, D.C. I know the American Hospital Association is the big lobbying association for hospitals. Are those lobbyists trying to keep this HCQIA law the way it is, or are they actually trying to change it?
Well, we're trying to take our show on the road and educate and so forth. I would say rather than push back, we've gotten no response. So we tried to contact the AMA, for example, no response there. But I'm not surprised. Healthcare entities aren't going to like this level of change. But you know what? I always say, don't sweep the dirt under the rug. So at some point, somebody's going to pull up the rug and see all this dirt. So just do it right from the beginning. Do healthcare right, advocate for the patient, do peer review right. If everything's done correctly, we don't need to, have star chambers, like you say.
Just one more question too. Why would the American Medical Association try to stop change here, or to not want this reform? It seems very common sense, and it would actually keep good physicians in the game longer, because you wouldn't have these disruptive physician sham peer reviews.
Right.
In your opinion?
I don't know. I mean, they've acknowledged that it exists, but they haven't moved towards reforming it.
Wow. It seems like a base level, even just ethics, human nature. We want to do the right thing here for patients. And
I'm such a purist.
Yeah. Well, how can people
if you hadn't
find,
noticed.
yeah, how can people find your work, and how can people find your proposal of this draft and maybe get some critical mass going to Washington with this and get it on people's desks that can make this change? Where can people find your work?
Oh, I have a Substack, and I don't have the address memorized, so I can give it to you, or maybe you have it.
Okay.
In
Is
the
it under, just
Substack,
under, if we look up Patti Robitaille, that probably come up on Substack?
yeah, so that has my initial proposal, outlining this is the problem, here it is in the law, here's the proposed remedy. And so that's like 30 pages long. And then I was told it had to be bullet points. So I tried to put my 30 pages down into a page or page and a half. It's got the draft legislation. Again, I was told section by section, bullet point of what's in each section of the draft legislation. So all four of those documents are there. And I think I also have a list of some peer review cases, yeah, as well.
Excellent. All right. So if anybody wants to change the culture at hospitals and make them accountable and change the law that is keeping them really from sham peer reviewing good physicians and pulling them out of the game, and that's a detriment to your family and your community, this is the proposal that needs to happen. So it's important people really activate here and get this to the people who can make the change in Washington.
And we would love feedback if you have been sham peer reviewed and you want to tell us your story. That would be great. Advertise to your, medical healthcare professionals in your family or your colleagues if you are a medical healthcare professional. All of that would be great.
All right. And how can they share that with you? Should they just reach out to you on Substack and message you for their stories, or?
That would be perfect.
Okay, wonderful, wonderful. Well, thank you again for joining me. I'm definitely going to circle back and in the near future for an interview, because I want to see how this is going, and I really think this is important to get onto the radar in Washington. There's a lot going on there, obviously, but this has to be one of the top priorities.
Yeah, so it's a busy place, that's for sure.
Yeah. So, thank you again, and we'll talk to you soon.